Hi guys, happy Cinco de Mayo and welcome to ChemoGlow, where the glow doesn't define me, I define the glow. We have a special show for you tonight and I will get back to that in just a moment. I want to make sure we do a little bit of housekeeping here. I want you guys to check out all of ChemoGlow's podcasts, which are available wherever you listen to podcasts. You can find us anywhere. It's not hard. They're available on Apple Podcasts, Google Podcasts, Spotify, Amazon, Audible.com, so many different places. So make sure you go back and you check out our podcast where available. ChemoGlow is live right now on YouTube. So if you are on YouTube, I need you to hit the subscribe button. Hit subscribe, give us a thumbs up. Give us a comment. Let us know that you're listening to us because we're on YouTube, Facebook, Twitter. ChemoGlow is everywhere. And if you want to share your glow, email us at chemoglow@gmail.com. We are already in the month of May. Can you believe it? We're already there. We have a great lineup for May. I'm so excited. Next week, Feng Wen, a lung cancer survivor, will be on. We're going to be talking about the stigma of lung cancer. You know, the first thing that she was always asked is like, were you a smoker? Who asked that? So it's so important for us to talk about lung cancer. So next week, she will be my guest. After that, Dr. Jacqueline Gaddy will be on. She's a medical oncology fellow at UNC. I actually had a chance to meet her when my husband and I were invited to sit down and talk to the fellows about how to talk to new people being diagnosed with cancer. So that was amazing, and I can't wait to have her on. At the end of the month, we're going to round it out with Dr. Carol Weaver. She is an author, breast cancer survivor, motivational speaker, and she's the author of Pies to Die For. This is her third book. Guys, I want you to pick up this book, read it, make sure you give her a review, and then join us at the end of the month. She is living with stage 4 metastatic cancer, and she is living her life, her best life. So make sure you check us out at the end of the month. I'm so excited about our lineup. Now, our guest tonight she's one of my favorites. Dr. Susan Kennedy. She is the Director of Breast Imaging Services at UNC REX Healthcare in Raleigh. But before we start, I want to show you a short little video about some of the things that we're going to be discussing tonight. Take a look.
I'm really excited to announce today that our group is the first in the Triangle to be using an AI software program for all our 3D screening mammograms. This artificial intelligence program is Profound AI, and it is aiding the radiologist in detecting breast cancers. When we went to 3D mammography, we went from having 4 images on a 2D mammogram to 400 plus images on a 3D mammogram. And that's a lot of images to look at and a lot of data. This software program analyzes that data and will place marks on the images for the radiologist to take a further, closer look. Profound AI is the first FDA-approved program to be used with 3D screening mammograms, and we are the first in the Triangle to make that part of our screening program, so we're really excited about that today.
Please welcome my guest, Dr. Kennedy. Hi.
Hi, Regina. How are you?
I am well. Thank you for joining me tonight. I know you've had a very busy day.
Well, I can always make time for you, Regina, and really the honor is mine that you're including me in your show with your guests, and I think it's such a great thing that you're doing because it's so important for people to talk about scary things and
Yes.
And to get it out there. And once you talk about it, it's really not as scary as you anticipated.
Yeah.
And I find that with a lot of the patients I see every day, when patients, come in for a breast biopsy, or I have to talk to them about their mammogram. You can see how anxious they are, and but once you explain what's going on, or once the procedure is done, they realize, gosh, it wasn't as bad as I thought it was. And that's why, talking about things that are tough always, I think, ends up with a better result.
It does. You walk out with a positive look at it versus I don't know what I'm doing and I don't even understand how many doctors I have to see. We were talking about this, and we were talking offline about, radiologists. What is a radiologist? What kind of radiologist are you going to see? Because you're seeing your oncologist, your radiologist, your surgical oncologist. It's just so much. So can you explain to us exactly what a radiologist does?
Sure. So a radiologist, I went to medical school just like all doctors do, and specialized in imaging. A radiologist is a person that can read anything from a chest CT to a mammogram to an ultrasound to doing an upper GI or barium enema or all kinds of OB ultrasounds. We read when patients are pregnant. But most of the radiologists today, because medicine is getting more and more complicated, subspecialize. And that's really what you want. A general radiologist can do a little bit of everything, but is not really as great as a subspecialist is.
Okay.
So in our practice, only the mammographers read mammograms. You don't have a general radiologist who's reading a head CT and then turning around and reading a mammogram, and then maybe reading an ultrasound after that. All of our radiologists are, again, subspecialized. And the reason why that's so important is you get really good at things you do a lot of. And I find in our mammography practice, all the mammographers, we tend to kind of read in unison. It's circular. So we do screening exams, we do diagnostic exams, we do the biopsies, and then we see the pathology results from those biopsies. So it's doing a lot of one thing that makes you, very, very, again, very good at it. So the technologist will take the mammogram films, and then the radiologist does the interpretation of those films. And I tell all my patients, radiology isn't like a blood test where if you go to any lab, your cholesterol level is going to be the same. The most important thing in a mammogram is the quality of the images and the person interpreting the exam. Is that person really good at picking up subtle changes? Because that's what you're depending on as far as getting the cancer detected and as early as possible. So I find that our group is really, we always try to stay on the cutting edge of imaging as far as quality of images. We were one of the first in the Triangle to introduce 3D mammography, which has been a game changer in the diagnosis.
How's that changed everything by doing 3D? Because, some people will say, well, I have very dense breasts, or they didn't see it on it. Why is it so important to have that option?
So breast cancer can present in many ways. It kind of, the cliff notes are breast cancer can present as a group of calcifications. People will hear, oh, you have calcifications. Now, calcifications are also a kind of a complicated subject because they're a spectrum. You can have very benign calcifications that we don't even pay attention to. But then you can have a group of calcification, and that can be the only marker of the breast cancer. So it can present as calcifications, but it can also present as a what we call a distortion. And I
Mm-hmm.
like to call a distortion, it's like a knot in your hair. Instead of the hair being nice and straight, there's like this pulling in of the hair,
Mm-hmm.
and it's the pulling in of the breast. On 2D mammograms, we couldn't see that distortion till it got very large. But with 3D, because it slices the breast into these thin little slices, the distortion pops right out. And that's why with 3D, it has been shown in the literature that the detection rate of breast cancer has improved by over 30%. So it's really, it was a leap in in
Breast cancer,
in
yeah.
breast cancer detection.
Because that was calcifications. That's the first thing they said for me. You have calcification. And they were asking me, did you drink this? Do you drink a lot of coffee? Is this here? And then I actually went and received a second opinion and at UNC. And they found out, yes, it is cancer. So calcifications, when I hear that, I don't think cancer. I just hear, okay, there's calcifications that they found. So it's important to know what kind of cancer it is, and it's on the spectrum, as you said.
And I think there's a lot of ladies that come in and they say, well, I don't want to have a mammogram because that might hurt, or, I just don't want to have that. I just want to have an ultrasound. And, I tell patients, well, ultrasound, we can see a mass on an ultrasound, but ultrasound can't see any calcifications. So we would be missing half the breast cancers out there that just present as calcifications. And calcifications seem like, oh, how could those little tiny white dots be anything?
Mm-hmm.
But they can be something big.
Yeah.
And it's very, very important to get the screening mammogram and to get it every year. I think there's been a little controversy in the media, some people saying, oh, well, you don't need it every year, you can do it every 2 years. And the American College of Radiology has stated it really needs to be every year. I see
year.
every day cancers that come up that weren't there the year before.
Yeah, every year. So what do you do when a patient says, look, my insurance will only pay for every 2 years, because now it's saying that every 2 years, that's when I can get one. Is there a way that that maybe they can come in every year to get that mammogram or request it?
Yeah, that is, the insurance issues today are just really terrible, and that's why insurance would love to say, oh, you only need it, every 2 years, because they don't really want to, it saves them a lot of money by not getting it done. Insurance is just it's just hard to get around. I do know that, some patients will say, I want to get it every year, and I'm going to pay out of pocket. I know our organization, if a patient is paying out of pocket, they get a discounted rate.
Oh, wow.
But the other thing is, I think, if there's any kind of family history, insurance companies, can't deny you getting that mammogram.
So advocating for your care is very important. Well, one of our listeners say that they really love, Africa Moore says she really loves how you're explaining 3D mammograms. It's very simple how you're explaining it so you can get the information. And she also had a question for you. She also wants to know, do you have to request a 3D mammogram, or do most places offer it? Do you know that?
If that's most breast places in the Triangle offer 3D mammography.
Okay.
And most centers I know are at REX and Wake Radiology REX. All of our centers have 3D, and usually the technologist will ask before doing the exam, do you want a 3D or 2D exam? I would say currently our screening exams, 95% of our patients are doing 3D mammography. Because again, it's just it's like taking a picture, going on a great vacation and going to Italy and taking a throwaway an old time
Mm-hmm.
throwaway camera versus having the best Nikon camera out there. Your pictures are
Exactly.
gonna be a lot better. You're gonna see a lot more, and so it's just such a newer technology that it makes no sense to
Not do it.
not to do it. Yes.
Well, Erica Mack wants to know, will there be an extra cost to 3D mammograms versus the 2D?
That's a great question. So initially, when our practice first started doing 3D mammography, there was a charge of $50 to do, and this is, oh gosh, probably 7 years ago. But now it's pretty much become the standard of care. So most insurance companies are covering 3D mammograms. You can always check with your insurance company. And when you go into a center, just have them, they can call your insurance company and help you check to make sure that it's covered. But most insurance companies are. Even Medicaid is covering 3D mammograms. So if Medicaid is covering it, it kind of pushes the other
Yes.
insurers to offer it.
Okay. Well, we have another question here. Are these 3D mammograms offered in Fayetteville? Do you know outside of the Triangle? Africa Moore wants to know that.
I'm not sure about Fayetteville. I would just, just call the center and just ask them if they offer it.
Okay.
I know pretty much everybody in Raleigh is, and in Raleigh in the Triangle, doing very, very little 2D exams. So I think, even in Henderson, they're doing 3D mammography. So even in the more remote areas. And the other kind of exciting thing that we're doing with 3D mammography is this artificial intelligence.
Yes.
So artificial intelligence, I describe it as like being the sensor on your car that beeps to alert you if you're, about to run over, the curb or run into the trash can as you're backing out of the garage. The artificial intelligence is a software program that is FDA approved, and it puts marks on the mammogram image. And we've had artificial intelligence for years now with 2D mammograms, but when 3D came around, there was no program for 3D mammograms. And basically, this is one of the first programs out there, but it will put marks on the film to draw the radiologist to say, hey, take an extra look here, for very, very subtle changes. And the way the software works is it has been fed thousands and thousands of proven breast cancers. So it learns that pattern recognition. And the more cases that the software is fed, the better the smarter that it gets. So every year the software is upgraded with more, thousands and thousands of pathology proven cancers. So it's, it learns what cancer looks like, the many different phases of cancer. So it's just an added safety net for the radiologist, because there is, with 3D mammogram, there are so many images now and so many places on the images to look. You can get distracted by looking at one area and not seeing a subtle change in another area.
How are the radiologists liking this new AI with helping them and supporting them?
It makes us feel better at night. I think it's like having almost like having a second reader behind you. So you feel like you're not going to miss anything, because you're not only looking where you would normally look, but you're doing a double check on certain areas. So it's really kind of for me, it's kind of an extra security blanket, so that I know I can feel good when I go home, that I didn't miss anything. I wasn't tired when I was reading an exam. And I think it's really exciting. I think there's been things in the news where Google found my cancer, and that's what they're talking about, AI software programs. Now, Google itself doesn't have an FDA approved program. There's only 2 programs that are FDA approved, and they had to go through a lot to get to that stage where the FDA would approve it. There's and our group is testing both AI software programs to see which we think is the best at detecting. So, and currently there is no additional charge for anyone on this AI program. So
I was just about to ask that. Is there additional charge on it?
No charge at all. So
when you explain this to your patients and you say, hey, I have something else that can help us detect breast cancer, how do they feel about it?
A lot of patients are really, really excited about it. I had a patient today, and I was showing her the program and where the marks were, and it gives kind of a percentage risk on the case, whether it's 80% risk that this is going to be a little cancer, and they're just really interested in the technology. I mean, technology is an amazing thing, particularly in radiology. I think that's why when I was in medical school, I wanted to go into radiology, because I just love the technology. Imaging, from mammography to CT to MRI, every year gets better and better and better. And there's just more we can do with it, with 3D reconstruction, and it's pretty amazing.
Well, in your position, how many things have you seen like change, and you're like, wow, this from when I first started and to where I'm at right now? What do you think about technology? Do you think we're catching up, or we're really at a good place right now?
I think artificial intelligence is going to be the next huge step. And fortunately for me, I'm on the tail end of my career, because pretty soon the computer is going to be reading. I mean, I don't think in the next 10 years, but maybe in the next 15, your mammogram will no longer be read by a human. It'll be read by a computer. Fortunately, the software and the artificial intelligence isn't there yet. It still marks a lot of things that are, not correct. When we go back to calcifications, the artificial intelligence will mark calcifications in a vessel, atherosclerotic calcification, that are benign. But because they look like the calcifications of a breast cancer, it's always marking any little vessel that it sees. So for now, I still have a job. And,
I have to say, for now, your job is safe.
Yeah.
And speaking of the job, becoming the director of its breast imaging services, what does that entail?
Well, it entails kind of running all our offices, making sure that we're putting the patient. I think our group's motto has always been what's best for the patient, and the best patient care we can give. So we try to have the highest standards for our technologists. We're constantly reviewing positioning on a mammogram, making sure the quality, again, that quality comes in, quality of the image is good. If we think there's poor positioning, that technologist gets flagged. and just keeping up with just high standard of care and service for our patients.
That is so important because Eugenia just said that she loves the new technology because it's saving lives. And she was diagnosed like she had a mammogram in 2002 and it was reported as calcification. And then in 2003, she was diagnosed with stage 3 breast cancer.
Oh,
So just knowing that there is a extra, technology there to help the radiologist and getting that diagnosis a year later, once you go for your yearly and you come back and the calcifications, now we're looking at stage 3 breast cancer. I know you see those cases.
I see, it seems like I'm seeing so many, as time is going on, it just seems like we're diagnosing more and more, cancers every day. And through the years, again, I guess because the technology has gotten so much better, we see cancers, thankfully earlier than we did. But it is pretty astounding, the numbers. And I think the hardest for me, of course, the hardest cases are, really young women with very aggressive cancers. It's not that they can't be treated. It's hard when somebody's young. It's hard when anybody's any age. But, when you have a 80-year-old with a tiny cancer, she's going to be fine. But when you have a 30-year-old with 3 kids at home and a very aggressive cancer, you want to just sit down and cry with them because you know how frightening that can be.
Yeah. It's so scary.
We try to, I think the one thing you can feel good about is just trying to get them on the next steps. We had recently a lady that came in. She was called back from a screening mammogram. There was an abnormality. She came in for her diagnostic, and it was clearly on the images, it looked like a cancer. So she was biopsied that day. The next day she had her results, and the next day she was in the surgeon's office. So within 3 days of her screening mammogram, she had her diagnosis and was in with the surgeon. And so you feel terrible that she has a cancer, but you feel good that you're getting her, moving along towards appropriate treatment.
Yeah, the wait time, for me, the wait time is so much. Erica Lee Mack says, as a radiologist, do you get to form relationships with the patients? It is wonderful that you want to share this information, but do you get to form any type of relationships? Like, how many times do you actually get to see your patient once you give them the reading of their mammogram?
Sure. So, and I guess I'll just say, the difference between a screening mammogram is a patient, has no current problems or no history of breast cancer, and they just get their mammogram done, and then we read that at a different time. With a diagnostic mammogram, the patient has either has a history of breast cancer or has a palpable abnormality, or is having a problem. So those exams are read while the radiologist is working. We're doing the diagnostic while the patient's there. We're getting the extra images. And so in our practice, we talk to all our patients. I know that's not done everywhere, but we feel if a patient is coming in for a diagnostic mammogram, the anxiety level is high enough that she deserves somebody to come either. Sometimes I'll show I always ask my patients, would you like to see your images? And at least show them their images and talk to them about what the findings are, instead of, you'll get your report in the mail. It's terrible. So,
or my chart.
Right, on my chart. So, we do form relationships with them when, especially when I do a biopsy, and then I have to call them and give them the results. And I say call. We used to never call. COVID made us call results
Oh.
because we were limiting the patients that came in, and
Hmm.
we used to have everybody come back to the office and discuss the results with them, because I think it's very difficult to tell somebody over the phone, that they have breast cancer. I don't like doing that.
Yeah.
I feel very uncomfortable with that, because
It's not the
it's
same. It's not that
hard. It's
human
really,
contact that you need to hear. I know I was waiting. I had a scare last September and I was waiting for the call, but luckily I volunteer and I work alongside some of the individuals, and I kept saying, well, who do I need to call? Because this wait time is taking a long time. But a lot of people don't have that option, but I still didn't get the call until, 5 o'clock that evening. But
well, there's been a recent change, and so I think now people are getting called even sooner. I have to say, at Rex and UNC, the pathology is great. When we do a biopsy,
mm-hmm,
our results are back um, 24 hours. So, I
mm-hmm,
mean, they're really quick turnaround time. But now there's been some change in the state regulations, where as soon as the pathologist reads that
mm-hmm.
pathology, that gets put in my chart.
Yes.
So, for a lot of our patients, as soon as the pathology comes off the fax machine, or we see it pop up in the computer, we used to call the referring physician first and see who they wanted the patient to see as far as a breast surgeon, and then we would call the patient. But now we call the patient immediately, because we don't want the patient to see those results and not have somebody to talk to right
Okay.
away.
And a lot of people don't know that's happening, that the results are now in your my chart. We were just talking about that at one of our council meetings, saying, hey, we have to make sure that the patients are aware of this and make sure that the doctors are following up, because how scary is that to read that something is in your my chart?
And I think, I've talked to the breast surgeons about this, because sometimes they have a patient might be have a biopsy done, that we're doing the biopsy, but at the same time they already have an appointment set up with the surgeon,
Mm-hmm.
not even knowing the results yet. And so the surgeon will get a call from a patient they haven't even met yet, because the results are just popping up so fast.
Oh, wow.
So, and it's, the pathology results are very, very complicated to read. And I think, um, again, we go back to that word of like scary. What we don't know scares us.
Yes.
And I think those results are complicated, and I think pretty overwhelming for most people.
Well,
Um,
that
and that's
ties
why
into, go ahead. I'm sorry, Dr. Kennedy.
when I talk to patients, I think all of us in our in my practice have a certain way that we like to talk about the results and kind of simplify things. I think one of the most common questions I get after a breast biopsy is, what stage is it? And
That was me.
at the time of, so there's two things that people need to know. There's something called grade, and then something called stage. And so at the time of a breast biopsy, where we're just taking a small amount of tissue from the area of concern, the pathologist will give it a grade, and they're graded 1 through 3. And the grade is based on how the cells look under the microscope. How far away from normal looking cells do these cells look? And so a grade 1 is a very low grade cancer, doesn't change very much. And even over maybe a year or so, might change very, very little. Then there's an intermediate grade, and then there's a high grade. And a high grade cancer will change, can change dramatically over, a 6-month time period. And those are the high grades from the ones you want to catch at the earliest possible stage.
So that really ties into what Jeanette was, she had a question. She said, when a mammogram is read, how do you know at that moment it is cancer? If so, do you tell the patient? I'm hearing several cases where this has happened.
So I think everyone as I said, in my section, in our breast section, I think we all have the same approach. And none of us really will tell a patient. There's certain times when you look at something on a mammogram, and I know 100% it's going to be a cancer. I mean, it looks like a cancer. There's no question in my mind. But I never tell the patient right immediately. I will not say the words, "this is cancer," until I have the pathology in front of me, because you would never want to make a mistake and call something cancer and have that patient, worried about it, and then the biopsy come back benign. And so I try to stay away from saying that just off of an image, because really the diagnosis is made with the pathology specimen. But I try to be honest with my patients, and so they'll say, well, are you concerned about it? And so I will say, this is very concerning to me, and or I if they really push me on it, I'll say, I'd be surprised if the biopsy didn't come back positive for a cancer. But I don't like to say it is, because I think I've heard too many times in the past where people have said things like that, and then it comes back and it's not. And that's a terrible, terrible, terrible thing to do. Plus, I think people need time to process. First you get the call that you're coming back from your screening mammogram. Mm-hmm. Then you're there and things aren't going away, and they're telling you need a biopsy. You just kind of have to, you don't want to throw things all at once at a patient. You just don't want to overwhelm people too much.
Yeah, it is very devastating, and you're actually being seen by different doctors. Like you said, they might have this appointment and all of a sudden they're going to go see a surgeon, but they haven't got everything they need. And now you're thinking, if I'm going to go see a surgeon, that must mean I have cancer. But they try to roll everything in one, which I appreciate when I'm going, that I'm not going to all these different places. I like that, I'm being seen by, all the doctors that need to care for me at that time. Mm-hmm. So that is nice to know. Mm-hmm. And everybody is saying this is such great information, because a lot of people don't understand, about going to get your mammogram versus the ultrasound, which you already explained to us. Mm-hmm. Is there some more things that you would like our audience to know about?
I think the number one thing is, I have so many patients come in, that are going to do a biopsy or their mammograms abnormal, and they say, well, I don't have any cancer in my family. I don't have anybody in my family with breast cancer. Mm-hmm. And the number, most patients that have breast cancer don't have any family members with breast cancer.
Yes.
So that does not matter. Of course, patients with a family history, it's even more important for them to come in. Kind of the rule of thumb is, if you have a mother with breast cancer, premenopausal breast cancer, so if your mother, you come in 5 years before. So if your mother was diagnosed with breast cancer at age 40, you would start getting your screening mammograms at age 35.
Okay.
And I like to see patients getting screening mammograms, anywhere. I think from 35 on. I rather start screening a little bit earlier than my 90-year-olds. I think, once you hit 90, it's okay. Because you always have to think, well, what am I going to do with the information that I have? Like, am I really going to do, it depends on your 90-year-old. If they're in great shape, then going to live another 10 years, then come on in. But But again, I only do exams that I would act on the information.
Okay, that is great.
And, I think the other thing I want patients to know is, even when I tell a patient that, the biopsy was consistent with the breast cancer, I think breast cancer gets lumped into, like all the same thing. Everybody just completely panics and, thinks that the story that their neighbor had is going to be their story, or and breast cancer is such a spectrum of disorder. Like a low grade cancer, acts completely different than a high grade cancer. And they're just completely two. There is like two different universes. And so I think just knowing that everybody's story is different, and because somebody that had a difficult time doesn't mean you're going to have a difficult time.
So true. So true. Well, James and Tasha Dawkins had a question. What is the recommendation for a patient to be screened if they have multiple breast cysts?
That's a great question. So, and we see I see breast cysts all the time. And 20 or 30 years ago, they used to, take them to surgery and take the cysts out, which was, now we think of that as just being totally crazy, because breast cysts do not cause cancer. They don't harm you. We don't drain them unless the only reason to drain a breast cyst is if it's so uncomfortable because it's getting larger. We will drain the cyst. But the problem with even draining a cyst is the body likes to fill up kind of cavities. And so a breast cyst is kind of like an empty, a balloon that's lost its air. And so the body will just over time fill it up again. And that's why we tend not to drain them, because they'll just reaccumulate. But breast cysts, a patient with breast cysts should get a mammogram every year, just like any other patient. They're not at any more increased risk. But it can be pain, I shouldn't say painful, but it can hurt. The compression can hurt because you're compressing those cysts. But again, it's just a few seconds of, discomfort.
Yeah, just a few seconds of discomfort. Going for a mammogram is so important, but so many people are scared to get a mammogram. And what I'm scared of is not being here for my girls.
Right.
So going to get that mammogram, or trying to tell people, please just go early detection with like low grade cancer, not knowing that you're looking for the stage and you're looking for the grade. A lot of people on here have no idea that those two things have to go together. Right.
So, number one, our problems never go away by ignoring them. They just get worse. So,
yes.
So, you just have to come in and maybe, tell yourself, like, if I come in for my mammogram, then I'm going to treat myself to something like a little shopping spree, like just reward yourself so that you can, just get it over with and then have a reward for doing it. And, just kind of reminding yourself of what time of year it was when you had it. When it's Christmas time, I just tell patients, okay, remember when it's Christmas, you have to come in for your mammogram, or remember when it's, Halloween, got to come in for your mammogram. And again, the reason why we screen is the smaller we can pick it up, the easier it is to treat and the less treatment you'll need.
Yeah.
So, it really is critical. And again, I think patients, they just, and it's just, again, with fear, we make up stories in our head of how bad things are going to be. And in reality, it is never as bad as we imagine.
Yeah.
And when I do breast biopsies on patients, most of my patients say, I'm afraid of, I'm not a good patient. I'm afraid of needles. Well, if you like needles, I would really worry about but all of them, I haven't had one patient say, that was terrible, or, that was worse than I imagined. Most patients are like, that was nothing. It's once you, as far as a biopsy, once you get the skin numb, it's much less than going to the dentist.
Yeah. I had
And
one done last year, and she was just talking to me the whole entire time. And I think I called you about it, and I was just like, oh, it was nothing. It actually went pretty well. I was more stressed out about going there during COVID than actually having the actual procedure done. We do have a couple more questions since we're getting to the top of the hour. I want to make sure I get these to you. Are there any recommendations for men for breast cancer? Or should they just do breast exams? Should they get breast mammograms? How does that work?
We do some, we don't really do screening on men, but they should do self-exams. It's
Okay.
not, I've had, a number of men with breast cancer. And it's strange how things happen. One year I had 3 male patients in the same month. It was just very, very strange how things can happen, in threes or at the same time. But it is really important for men to do self-examine. And if they feel anything palpable, and this goes back to my cyst patient, if you think anything palpable that is new, come in. Don't assume it's a cyst. Don't assume it's nothing for men. The only way to know what it is with a mammogram and with ultrasound.
Yeah. Well, we have another question here from Erica. How much training did you get on the new AI system, and how long did it take for you to get comfortable using it?
That's a great question. And the great news is, so the 2 different companies that came spent a week with all the radiologists, showing us how to kind of, it's something that we click on. We click it on, and we can click it off to see the images without the marks on it. And it's pretty easy to use. It's very user friendly. It's not complicated at all. It's kind of an overlay that goes on to the images. But it takes a long time to just physically install, and it's more of a IT nightmare because of the added information. But it was a week with each company that sat with all our radiologists. And one of the companies that we worked with, whose name is called Profound, they just had an upgrade for us. So they were at our office today, actually, working on the upgrade of the next generation. And and with each generation, it's somewhat interesting that each generation has to get FDA approval. You would think once one generation got FDA approval that all the upgrades wouldn't need it, but each one needs FDA approval.
That makes me feel a little better.
Yeah. But it's really exciting. And again, now I don't want to read without it, because it's, again, the safety net. Okay, I didn't overlook anything. I didn't miss anything, because the reading the mammogram is based on the person sitting in that seat reading it. And
that is so important.
You want to make sure it's not not somebody who's not real interested in mammography.
That's
So
so true. The person that's reading that mammogram, the doctor that's reading that mammogram, is just as important as the surgeon that is going to have to do surgery on you,
yes,
because you
we
want them to do it. You want them to
we
do it
work
well.
exactly. We work really close with the surgeons at Rex, and they, they refer us cases from the outside that they want us to look over for second reads, and it is a team effort. And even in the office, I say to my ultrasound techs, we're all working together, and we all need to do a top-notch job, so that we can make the best diagnosis and give the best patient care. It's not just me. If the technologist doesn't get that breast tissue, on the image, and it's not imaged, you could miss a cancer,
Mm,
because it's just, it's far back in the chest, and they didn't pull the breast in enough, um, or she had motion, so you couldn't see the calcs clearly. They were blurred out. So it takes a team. We're always working as a team with the technologists, with the surgeons. Every Tuesday morning, Rex has a breast cancer conference,
mm-hmm.
and it's the oncologists, it's the surgeons, and it's the radiologists, where we present cases, and it's a real team discussion about how the patient should be managed. If there's any questions, getting thoughts from the whole team on how what would help to help manage the patient better.
I've actually had the pleasure of sitting in on one of those at UNC. They used to call them tumor boards, and
They're still called tumor
tumor.
boards.
So sitting in as I was volunteering for some project they asked me to do, they said, "I want you to see how everything works," and I was so amazed to see, you know, the people's screens up there, what's going on, and every doctor having a say and saying what's best. So you're not just going to one person. It's truly a team effort. And what was interesting is if they didn't agree on something, someone will say, well, let's think this thing out. What's the best treatment? And then I also was able to see how many people come outside of the triangle to come here
Mm-hmm.
for the best treatment, because I've been treated at Rex and at UNC for something. I don't want to go back.
Right, right, right.
I'm good now. I just
Right.
want to go for my yearly. But we did have a question here. Had a question regarding the age for mammograms. Doctor answered it. Regina, thank you so much. Well, thank you, Miss Kelly. But yeah, what are the age for mammograms? Is it still 45?
The starting age to begin screening mammograms is age 40,
Okay.
except if you have a family history of breast cancer, and then you would begin 5 years before.
Okay.
So it would be with a premenopausal mom, because if your mom was, say, 60, you'd still start your screening at age 40. At age 40, and then every year after.
Okay. Because I remember when they changed it to 45, I think the American Cancer Society. And
there's been a lot of confusing
yeah,
information, but the American College of Radiology still says 40. And, I again, I've seen so many cancers, younger patients. And of course, if you have a palpable abnormality or you notice something, doesn't matter whether you're 40 or not. If you're 29, you come in, because, unfortunately, I've seen, thankfully not a lot, but I've seen cancers in, late 20-year-olds.
yeah.
And again, really heartbreaking. But always get any abnormality checked out.
Well, thank you so much, Dr. Kennedy. I'm
It's a
so
pleasure.
happy that you came on. I want to make sure that we haven't missed anything. We have a lot of people who said thank you for being an advocate for the patient. Erica just said that, getting the best care. It's nothing like having an amazing doctor to watch over you. You have that human connection. So I want to thank you, but I want to make sure we also got all of your talking points, everything that you would like to share with our audience. Is there anything, we're at the top of the hour, any last words you would like to say to the audience before we end our show?
Just that everyone encourage your neighbor, your sister, your mom to get their mammogram and be proactive.
And men, still do your self
Exam.
on yourself. Well, Dr. Kennedy, thank you so much for coming on. Did we have another question before I go off? I think we've already answered that. Everybody just said great discussion. Well, stay on in the backstage because I want to talk to you. Guys, thank you so much for joining us for ChemoGlow Live. This was a awesome discussion. If you have questions for Dr. Kennedy at any time after this, please just put it in the comments and I will get it to her. But thank you again. Next week, please come see us on Wednesday. We'll have Fawn Nguyen, lung cancer survivor. Great person. I can't wait to sit and talk with her. But thank you guys. Just remember that the glow doesn't define me. I define the glow. You guys have a great evening. Bye.